Hello, my name is Alistair McNarry. I'm an anaesthetist based in Edinburgh, and it's my privilege to welcome you to this edition of the Airway Management Podcast from Medtronic, the manufacturer of the McGrath Mac video laryngoscope. In this series of 4 podcasts, we're taking a deep dive into the multifaceted world of video laryngoscopy. A technique that I would like to say has changed my practice, I think probably has revolutionized worldwide practice in airway management, and certainly how we manage the airway in and outside the operating room. In these 4 podcasts then, we're looking at the evidence for video laryngoscopy, the role of video laryngoscopy in pediatrics, teaching and training in video laryngoscopy, and a look at the role of hyperangulated video laryngoscopy. So please join us, listen in as we uncover the versatility and impact of the video laryngoscope on airway management in modern healthcare. In today's episode, I'm delighted to be joined by 2 experts in the airway world, Professor Ellen O'Sullivan from Dublin and Dr. Jan Hansel from, Manchester's not really the right phrase, but working in Manchester at the moment. Tell you what, I'll let them introduce themselves and they can explain it all.
Thank you, Alistair. Thank you for the kind intro. My name is Jan Hansel and I am a registrar in anesthetics and intensive care medicine, about to pursue a doctoral fellowship funded by NIHR as well soon. And my interest is in airway management safety. I was the first author of a Cochrane systematic review looking at video laryngoscopy. And you told us to give a fun fact about ourselves. Is that correct?
Please do. If you've got a fun fact, please do.
I think I do. I have. I would say my favorite dessert is Nutella, and it needs to be pronounced as Nutella, not Nutella, as some listeners may not be aware of. So, yeah.
Obviously, we shan't ask you to choose between the difference of Nutella with a spoon or a video laryngoscope.
Nutella with a spoon, definitely. Yeah.
To Professor O'Sullivan and say, Professor O'Sullivan, tell us a bit about yourself.
As you mentioned, I work in Dublin in Ireland in a large teaching hospital there, St. James's Hospital. And I have great fun there because it's a big head and neck, max fax, burns unit. So we have a lot of opportunities to practice one of my main interests, which is airway management and in particular difficult airway management. I actually trained in the UK and had the pleasure then of training and being a consultant in Aintree Hospital, where I worked with Peter Charters, who was, I suppose, one of the founding members of the DAS and also got me involved in airway management. So that's kind of a bit of a summary.
So in our other podcasts, we've been talking a lot about video laryngoscopy, and this one is really a chance to drill down into the evidence for video laryngoscopy. And I think I'm very tempted, given Jan's background, to jump straight into the Cochrane review, but I wonder if either would fancy tackling the early studies in video laryngoscopy, because they seem to tell us that you get a view, but you couldn't get the tube in. And early meta-analysis didn't seem to say that actually video laryngoscopes were that successful. What were we missing? Why are we all raving about video laryngoscopy now?
Not at all, on the contrary. But let's start at the beginning, because I think Al and I, unlike Jan, would have started our practice before the days we never heard the term video laryngoscopy. And then in the 2000s, when Jack Pacey, a surgeon, in fact, developed the glide scope, we pricked up our ears, and then there was an RCT in the BJA on that, in the BJA on that in the kind of early 2000s. And we were all fascinated by this. There was no terminology of hyperangulated or, MAC style VL, but we all started to think about VLs, and then the studies started to come, as Alistair said, small studies, small numbers, and we got our hands on them then and thought, oh my goodness, we get a view, but we can't get the tube in. So that was the kind of, when seeing is believing and you can't get the tube in. So that was the big problem, essentially, with the VLs. But remember, all of those back then would have been more angulated than our standard Macintosh laryngoscope. So it comes right up then to that Cochrane review you mentioned in 2016 by Lewis et al. Big review, we thought, showing some benefit, all right, from VL. But that was followed on then by the most recent Cochrane review in 2022, which was, I would say, a major milestone. And we're lucky to have the main author here, Jan. So maybe this is a good time, Alistair, to hand over to Jan to discuss that.
Jan, I'm afraid this has to be your question, because as I'm taught, the top level of evidence available for anything is a Cochrane review. And we're lucky enough to have you here as the first author of the Cochrane review into video laryngoscopy that was published in 2022. I think before we get into the nitty-gritty of the review itself, lots of our listeners will know that Cochrane reviews are really good for evidence, but what actually is a Cochrane review?
Okay, so simply a Cochrane review is a systematic review, usually with a meta-analysis that is published on the Cochrane database of systematic reviews. Why it's so special is because it is underpinned by a very rigorous methodology, a very systematic search, and it follows a certain set of guidelines on how systematic reviews should be done. Some would argue it's the gold standard that we have in terms of synthesis of evidence that is available.
And so what was the background of that 2022 review? I know there was a review in 2016. I thought that told us all of the answers we needed. Why did you need another one in 2022?
Well, the 2016 review was excellent in the sense that it highlighted effect estimates of video laryngoscopy being superior to direct laryngoscopy. However, as you mentioned heterogeneity previously, there was a lot of heterogeneity in that review. So we had studies of hyperangulated blades, Macintosh blades, channeled video laryngoscopes, all combined into one. So we threw them all in a bag and said, this is the estimate that we have here. Now, our review in 2022 built on that, and we essentially divided those three into three categories to decrease the heterogeneity.
Again, just for our listeners, what's heterogeneity? What do you mean when you say that as a scientist?
Excellent. Thank you, Al. I feel like I'm in a Viva right now. Good prep. So heterogeneity can be clinical or statistical heterogeneity. We encounter clinical heterogeneity in our daily clinical lives when we treat different patients. They aren't the same, and groups of patients and cohorts aren't the same either. So combining those cohorts from various studies from, say, the UK, Europe, the States will not be the same, obviously. Statistical heterogeneity then is layered on top of clinical heterogeneity, and we have ways of dealing with statistical heterogeneity, whereas with clinical heterogeneity, we need to identify it and try to mitigate it, if that makes sense.
And what did that actually tell us about video laryngoscopy and first pass success, video laryngoscopy and hypoxia, video laryngoscopy and assault? I know you wrote 590 pages, but please, if you could just summarize the detail in a couple of sentences.
Perhaps taking first pass success and failed intubation as two converse outcomes across the board for hyperangulated Macintosh style and channeled video laryngoscopes, we had better performance of video laryngoscopy in our review. Esophageal intubation was a bit more nuanced, where we only identified statistical superiority of video laryngoscopy for hyperangulated devices. However, this depends somewhat on the statistical approach chosen, but also whether you think there is face validity to hyperangulated devices only improving rates of esophageal intubation or decreasing rates of esophageal intubation.
So I'm going to say I'm confused because my statistical knowledge is nothing like yours. If first pass success improves, which you said it did for everything, if the tube goes in the trachea first time more of the time, surely it can't go in the esophagus
as often. Precisely. I mean, the problem with that is that we have rare events, and we're looking at rare events with imperfect tools, RCTs that are cherry-picked, and we have small studies, as we mentioned previously. Alan alluded to the fact that we had small studies initially, and then these studies grew larger and larger. And actually, after the 2022 Cochrane review, we started getting big trials of video laryngoscopy versus direct laryngoscopy, which we will touch upon in a bit. But these are rare events, and you can easily impute that increased first pass success rates would lead to lower failure rates, would lead to lower esophageal intubation rates, which probably is true. But the studies that have been included into this review perhaps might not detect those events because they're rare.
So we have evidence, but I know you were involved in another article with Karim El-Bogdadli. Now let me get this right, because this is where you start getting an evidence-based trial sequential analysis. That's far too many words in a row for me. Perhaps you could unpick it for our listeners. What is a sequential analysis of trials? And perhaps more importantly, what does it tell Ellen and I about what we should be doing with video laryngoscopy? Where does it put the evidence?
Perfect. Okay, so I'll just briefly outline what a trial sequential analysis is. So imagine all of the 222 studies that were dumped into the Cochrane review and line them up on the x-axis in chronological order. So you start in 2004, which I think was when we had the first studies, and then line them up on the x-axis. And over time, you will then plot essentially the p-value, and it will go either in favor of direct laryngoscopy or video laryngoscopy. It happened to trend towards video laryngoscopy being more favorable most of the time. Some studies did, in fact, show that direct laryngoscopy was better. Those studies will have been pre-hospital studies, for example, and there you can start analyzing why that might have been the case. But that line started trending upwards, and I would invite listeners to potentially read our editorial as well and look at that. But essentially, it gives us what we call the required information size. So at some point, we will have reached a threshold where we have enough evidence. And that threshold was actually reached in 2017, as you rightly pointed out. So we've had enough of evidence of that specific question, and we probably need to move on to different questions.
Okay, so I'm not gonna dwell on the fact that actually we knew video laryngoscopy was better before you published your outstanding meta-analysis in Cochrane Review. But I do know, Professor O'Sullivan, maybe this is one for you, that there was a huge study of the McGrath-Mac laryngoscope, the EMMA trial. Now, it was published after the Cochrane Review, after we knew there was enough evidence. But what did we learn from the EMMA trial? For it had big numbers and was very impressive.
Yeah, I think it had over 2,000 patients, one of the better RCTs by Krieg and his colleagues in Germany. And they found VL perform, first pass success was 94% with VL versus 82% with the DL. So a very definitive result. But as you said, it came after the Cochrane Review. But remember, after the Cochrane Review, we were still having debates, just to put it in chronological order. We thought, done and dusted. But no, there was a lot of debates, public spats between people about VL versus DL. But now we've had at least the EMMA trial and 3 more, at least, big, large RCTs. 2 stopped because of the fact that the VL was outperforming DL statistically and had to be discontinued, like the cluster trial in Cleveland Clinic, the crossover cluster trial by Ritzler and his colleagues, and also the device study trial in America.
I'm glad you've mentioned the device trial, because I'm trying to look intelligent. I'd read up about it. But why was the device trial so important? Because it was ICUs and emergency departments, wasn't it?
Very important, because I think that's where you get the physiologically difficult airways as well, and the rapid sequence intubations. So a very important group. Also, the people performing the intubations were less experienced. So there's a lot to learn, and considering the numbers, there was nearly 1,417 participants in that study, which was stopped early because the first pass success was 85% with VL, so lowish, but 70.9% with DL. So they were performing very badly. So that was very interesting, and it was published in the New England Journal. So I think it was recognised by everybody as a very important study, and a very well conducted study in, I think, about 7 sites it was in. So a very, very big study, and we learned lots about, I say, the importance of VL and its first pass success, but also the experience of the operators. The big lesson I learned from that was the inexperienced operators who had done less than 25 intubations performed much better first-handed a VL versus a DL, and that's changed my practice. If they're handed a DL, they perform badly, and it takes them longer to reach the satisfactory curve. If they're handed a VL, they perform better, quicker. And again, that's a secondary kind of analysis, but it's very, I think, very interesting and very practical from a teaching point of view.
Just for people listening to the fast flow of this debate, DL, direct laryngoscope, one without a screen, VL, video laryngoscope, one with a screen. One of the other studies trying to look intelligent that caught my eye, maybe this is one for you, Jan, that looked at the McGrath, published this year, see, I'm very current, in 2024, looking at the McGrath in rapid sequence induction.
Yes, yeah, another study by Krieger and colleagues that looked at, I think, more than 1,000 patients that underwent rapid sequence induction and intubation in the perioperative setting in theater. Again, noting superiority of the McGrath-Mac compared to direct laryngoscopy. And I think just top-level message here is that these large trials are now confirming the message that we've demonstrated with the Cochrane Review. And we can probably shift towards slightly more tailored questions, like which type of video laryngoscope performs better than the other, rather than comparing video laryngoscopy to a more data technology.
And do you think, because I'm just thinking listeners may have looked, if you look at the term video laryngoscopy, you come up with things like Mike Aziz's study in 2011, looking at 2004 uses of a device with a hyperangulated blade. Are case series old hat? Do they not have any bearing on clinical practice anymore?
I think they absolutely do. I think randomized controlled trials are not the be-all, end-all of evidence, and we need to look more widely. We need registries, for example, that will show us rare events and how video laryngoscopy performs, or specific types of video laryngoscopes perform with minimizing the risk of rare events occurring, such as esophageal intubation or undetected esophageal intubation, or death for that matter, because no trial will detect that, no matter how large it is or how well powered it is.
I'm very interested that you've mentioned esophageal intubation, just as you have a certain vested interest in the second Cochrane review. I know that Professor Sullivan, you were part of the PUMA group that wrote guidelines on esophageal intubation. And again, just for our listeners, we are bandying about acronyms all day. PUMA were the Project for the Universal Management of the Airway. But a couple of years ago, you produced some. Well, were they quite I don't think you were quite the first group to say universal video laryngoscopy, but you were one of the first groups to say, actually, safety-wise, you should use a video laryngoscope whenever possible. But tell us a little bit about the PUMA guidelines on esophageal intubation. Yeah,
as you said, the PUMA is this group, international group of anaesthetists, intensivists and emergency physicians from 4 continents around the world that got together to look at universality really within all the guidelines. But we were a little bit sidetracked and did this project first on a guideline to prevent unrecognised esophageal intubation because one didn't exist. And this really stemmed from a seminal case in the UK of a death from unrecognised esophageal intubation, which reached kind of widespread the headlines, and we wanted something to prevent it. And the best way to prevent it is to success at first pass. You can detect it perhaps with capnography, but the important thing is to prevent it in the first place. So looking at all the literature and reviewing the cases and so forth, it was felt that the first recommendation would be use VL as first line for all intubations. So if feasible is added, because we know that there is not universal availability of video laryngoscopy everywhere, in particular low middle income countries, and we have some studies to show that it is not available in some countries at all. So we had to say if feasible, meaning that people should work towards getting VL for all intubations.
Now, I happen to know that one of the podcasts in this series looks at hyperangulated video laryngoscopy, and I happen to know that in that there might be a little debate about the use of stillets and bougies. But when I have 2 evidence experts in front of me, it would seem the same not to ask what's the evidence for stillets, bougies, video laryngoscopy. I'm getting the feeling, Jan, you're going to tackle this first, but Professor O'Sullivan, you're going to have a go too.
Yeah, there have been a number of studies on this topic, because we know when you use a hyperangulated blade, you need an adjunct. Traditionally, in, I would say, UK and Ireland, we've used bougies as adjuncts for intubation. Maybe in the other parts of the world, they usually use stillets, maybe even first line. But there's been a number of studies looking at that, not very big studies. The Stiletto study was published showing the advantage of stillets over bougies, but there's equally the driver study looking at bougies, showing bougies perform better. So I think it's an area for further research, definitely, because the evidence at the moment doesn't really, it's more what's the experience in the particular training area or country, even for that matter.
Absolutely. I think the important thing to remember, though, is that hyperangulated video laryngoscopy is very different to a Macintosh-style video laryngoscope, and we ideally need an adjunct that is able to follow the curve of the blade. And the rigid stillets that have been designed by various manufacturers for their given devices seem to have performed well historically. Now, a recent study showed that bougies outperformed the glide ride stillet for specifically CMAC-D blade. Now, that goes against the grain of current understanding of how we use hyperangulated devices. And the question is this the final message? I would argue that probably not, and we shouldn't necessarily be changing practice based on this one study alone.
So this is interesting because a little while ago, an eminent expert told me we had all the evidence we needed, and we now seem to be we seem to have arrived at a question which I can't but resist asking. So do we need more studies, Doctor?
Yes, we do. Yeah.
So what do you think the next studies need to be looking at? I mean, young researchers out there wanted to emulate you. What should they be doing their Cochrane review into?
Well, I think now that we've answer the question of video laryngoscopy performing better than direct laryngoscopy, we should move towards how we can refine that technique, and specifically looking at hyperangulated video laryngoscopy and which adjuncts we can use to best serve our patients and secure the airway quicker. And in terms of what sort of studies, it may be difficult to power studies sufficiently with predicted difficult airways and actual difficult airways clinically. So who knows, perhaps mannequin studies might be useful to guide us in the right direction, but I think we need larger pragmatic studies of various adjuncts as well. Yeah.
Now, we've got to kind of look back with a degree of caution to 2020, because airway management did change in the COVID pandemic, and guidelines in airway management changed in COVID pandemic. And COVID guidelines said use a video laryngoscope. And I know that actually the Intubate COVID study showed that people did use a video laryngoscope first line. Has that been sustained, or are we winding back from that? Or why do people not carry on doing that?
Interesting, because yes, we were all using VL for COVID. Nothing else was being used. But obviously the number of intubations done were limited to mainly intensive care and probably intensive care consultants, versus a lot of anaesthetists weren't intubating as much. We weren't doing routine surgery. That's one of the explanations perhaps. But I know that when the VIQ survey was published in 2022, and Alistair, I know you were involved in that, there were over 4,400 responded from 96 countries. And the use had gone up during COVID, come back down post-COVID from to 50%. So it had come right down post-COVID. But I think now, even since then, there's been more research published. Also, the guidelines haven't changed. The guidelines are now beginning to reflect the evidence. The Canadian Airway Focus Group in 2021 definitively said use VL as first choice for intubation, followed then by, as I say, the PUMA guidelines. The DAS guidelines were last published in 2015. They sat on the fence in the sense said use DL, but have availability and skill in the use of VL was a recommendation. But now the DAS guidelines are being revised. They'll be published hopefully next year, and I suspect they will obviously follow the evidence as well and say VL should be first line for intubation.
I think the evidence you presented today has been really very compelling, but I think in all of these podcasts I've been issuing a safety notice. And whilst I want people to change their practice based on what they've heard, I also want people only to change their practice in a safe way. And that's in a way where they have been taught video laryngoscopy and taught to use it effectively, and that they're using the device that they have available in their institution, and they're prioritizing oxygenation of the patient over everything else. It's great to look at the evidence, and this is exactly how we should be forming our practice. But if you're listening to this podcast as a trainee, please develop your practice under the supervision of someone who's teaching you what to do and teaching you to prioritize oxygenation at all times. So I think it's clear we could talk on for another hour on the subject of the evidence for and against video laryngoscopy and which blade type we should use and whether we should use a bougie or stylet. And I'm delighted to have had Professor O'Sullivan.
Thank you very much.
And Dr. Hansel.
Thank you.
Sharing their thoughts and their insights with us. But I think that's probably about the end of our time together. I'd like to thank Medtronic for sponsoring this podcast series. But most importantly, I'd like to thank you, the listener, for tuning in. And hopefully this has been useful to you and influences your practice and your discussions around video laryngoscopy in your department. If you've enjoyed the discussion, please tell your friends, please tell your colleagues, please encourage them to have a listen, please pass comment, and please listen to the other 3 podcasts in the series as we explore how video laryngoscopy can advance our patient care by improving oxygenation, by improving first pass success, and by preventing trauma and esophageal intubation. Thanks for your time.